his residency in internal medicine at the University of California, San Francisco, where he then served an extra year as chief medical resident. Oops, I just clicked off your bio sketch there. Hold on a second. Sorry, everybody. Sorry, Ed. So right now, Dr. Vasilevskis is Associate Professor of Medicine at Vanderbilt University Medical Center and a staff physician with the Tennessee Valley VA Geriatric Research Education and Clinical Center. Dr. Vasilevskis' research has focused on acute and post-acute care of older adults. His work has included the implementation of new care models to aid transitions from the hospital to post-acute care settings, as well as the care of the delirious patient. Most recently, Dr. Vasilevskis has been the co-PI for a National Institute on Aging sponsored trial that is investigating the medication and geriatric syndrome outcomes, including delirium, dementia, and depression, of a patient-centered medication de-prescribing model called SHEDmeds. I'm proud to say Dr. Vasilevskis has been a colleague and a friend in hospital medicine. He is greatly admired across the country in hospital medicine, and we're fortunate to have him speak to us today. So welcome, Ed.
Great, Dan, thanks for that great introduction. And thank you so much for inviting me. It's really a pleasure to be here. And so wish I could be there in person maybe next time. And so, but Zoom will do. Just want to let you know I have nothing to disclose, no kind of personal professional relationships, and everything I'll be talking about is evidence-based. So I have a few objectives today. As mentioned, my background is predominantly in the older care of the acutely hospitalized patient. And recently I've become increasingly interested in the role of de-prescribing and polypharmacy among our older inpatients. So at first, I'm just going to talk about the epidemiology, a little bit about what we know. There's a whole bunch out there. I'm just going to touch the surface, talk about some of the outcomes. There are many outcomes. If you name it, one can link a adverse outcome with polypharmacy. I'm going to talk a little bit about what we know about de-prescribing, that is reducing medicines among our older inpatients. And then finally talk about some of the work we've been doing here at Vanderbilt called SHEDmeds. We have another corollary study called DropMed in the VA, which is focused on de-prescribing in acutely ill patients who are transitioning to post-acute care. I'm going to start with a case. This is a patient I saw not too long ago. This was a 48-year-old woman, so not an older patient, but you'll find that she has a number of features which are consistent with geriatric syndromes, which is why I'm speaking about her. She had recently moved to Tennessee. She had a history of lupus with necrotizing vasculitis, PTSD. It was unclear if she had a seizure disorder. It was hard to confirm with the documentation. And she had a chronic pain syndrome. And 10 days prior to admission, she developed some right greater than left pleuritic chest pain. She had no fevers or cough. And on the morning of the admission, the patient's hip, quote unquote, gave out. She fell on her right side and had immediate chest pain on the right side following this. She had a past surgical history of a cholecystectomy. I'm just going to briefly talk about her hospital course. Her EKG was normal. She had negative troponins. She had no evidence of pulmonary embolism by CTA, but she was found to have multiple right-sided rib fractures. She had a TTE, which had no pericardial effusion. Rheumatology was engaged, and they thought it was very unlikely to be a lupus flare. And a pain team was consulted for acute pain control for these rib fractures. Now, of course, I bring her up because I'm focused on polypharmacy, and this was the patient's medication list. In green are newly prescribed medicines that happened in the hospital. In black were all pre-hospital medicines that she came in on. In red was one medicine which had been held at the time of her admission, and that was naproxen, because the patient did have some acute kidney injury. But you can see here a list of 31 total medications. Now, of course, this is an extreme case, but I will show you data for our patients who are going to skilled nursing facilities, and it is typically about half of that number. And you'll notice here there's a number of medications which list from pain medicines, sedative medicines, anticholinergic medicines, PPIs, a lot of laxative medicines, sleep medicines, anti-seizure medicines, and medicines for the patient's lupus. But a number of them. And this is actually my note that I wrote. I added a problem. I had just taken over this patient on hospital day 7. And so here we are, day 7. And I added a new problem. The new problem was called polypharmacy. And I said I discussed the hyperpolypharmacy with numerous sedative, hypnotic, and psychoactive medications that had high potential to play a role in the patient's recent fall and debility. Many of the medications in discussion, for example, Lyrica and Robaxin, were added during an acute medical crisis. However, they were never titrated back to off. And most concerning medications included the following, and I listed a long host of medicines. I said, for now, the patient was willing to begin titrating down on some of the existing medicines with further reductions that can occur when she goes to rehab and when she connects with her regular physicians. And my first steps that day, I reduced the clonazepam to 1.5 milligrams from 2 milligrams. We reduced her pregabalin to 75 milligrams from 3 times a day to 2 times a day. And we changed her methocarbamol from scheduled to PRN as an initial step. And we'll come back to that case and see what happened and follow up at the end. So the first thing is, I just want to talk about, is this patient truly abnormal? What do we know about polypharmacy among our older hospitalized patients? Well, first we should define what polypharmacy is. In polypharmacy, there's not a strict definition, but generally people agree 5 or more medicines, you'll see 6 or more, is defined as polypharmacy. And then there's the term hyperpolypharmacy, which generally is 9 or more medicines that a patient is taking. Now, how did I get interested in this? I'm going to bring you a little bit from the history of my research. As noted, some of my earlier research was focused on improving care models for transitions from the hospital system to the post-acute care space. And we were lucky to be funded by CMS for an innovation award, as well as through the VA through a T21, to try to come up with an improved care model. We called it Impact Interact, which improved the transitions of care from the hospital to the post-acute care setting. And really, we were trying to create a closed loop communication system, as well as closed loop evaluation of outcomes, as well as geriatric syndromes across the space. And I'm not going to spend much time talking about the care model, but I will note that a couple of things which we did do systematically was identify patients' geriatric syndromes, those including dementia, delirium, falls, functional impairment, weight loss, incontinence. And we did a robust medication reconciliation at hospital discharge. Now, the medication reconciliation, importantly, was just making sure that we had the correct medicine list, the right medicines that the patient came in on. And when I say right, I guess I should say it's not the correct medicine, but it was the lists matched. And one thing we didn't do was try to change the medicines. And what we realized over time was that our patients were on a whole bunch of medicines. And they also had a large number of geriatric syndromes. And that's really when we had the aha moment of saying, I wonder if we should be doing something about these medications to try to reduce them, because we're clearly trying to improve the transitions among these patients with geriatric syndromes. But what we found was these patients, 98% of them met criteria for polypharmacy. 83% of them had hyperpolypharmacy. These were Vanderbilt patients going to a post-acute care, that meaning a SNF, a skilled nursing facility, or an acute care rehab facility. The average number of medications among these patients was 14, and the average number at the skilled nursing facility discharge was 15. And then when we looked at the potentially inappropriate medicines as measured by the Beers list, one can see that there was about 2.2 medications on admission and then 2.2 at discharge, and there was a little bit of change of adding and subtracting, but the net was the same. We found the exact same thing at the VA. And when one looks at the literature, we were surprised, or maybe shouldn't have been surprised, to see that in a VA study where they looked at patients from the hospital to skilled nursing, that they had almost the exact same number of medications in the EM study in 2016. So our patients leaving the hospital are on a very large number of medications, and this is what's been found nationwide as well. So our takeaway from our Impact Interact CMS study, we did have some modest improvements in 30-day readmission, but what we really discovered was the medication list was accurate that we had, but we felt like there was too high of a prevalence of polypharmacy and hyperpolypharmacy. Now, just to look at a little bit more of some national data, what I'm presenting here is some older data from 2008 through 9. And this is Medicare data looking nationwide, a full Medicare sample among all patients hospitalized with acute myocardial infarction. So it's over 100,000 patients around the nation. And what they looked at was any patient who had a continuous PIM, potentially inappropriate medication, which was basically the Beers List medication that one would find from the American Geriatric Society. And they said, what was the prevalence among those patients who were hospitalized just for acute myocardial infarction? So once again, these are not necessarily all geriatric, this is all comers, but it is Medicare, so predominantly 65 and older. And so what they found was that there was a striking prevalence. I put here the map of the SEC where I come from, Tennessee. And as you may be familiar, sometimes outcomes and measurements like this don't look so well. But there was a whole host of potentially inappropriate medications, and it ranged anywhere from 1 to 5% in certain areas of the country. And where I am, it was 10 to 18% of patients were coming into the hospital on a potentially inappropriate medicine. Overall, when people looked at the period prevalence from 6 months before hospitalization to 6 months after hospitalization, the prevalence of potentially inappropriate medicines was about 25% of patients. Furthermore, there was an increase, pretty much I could have this exact same map of about 1 to 2 potentially inappropriate medications, with the worst outcomes being where I live, unfortunately. Now, when I have spoken to my fellow hospitalists, one of the questions I like to ask is, how would you describe your patient's medication list at the time of hospital discharge? And so I happened to take a screenshot of one of the poll everywhere. And this is what my hospitalist said in Nashville, Tennessee at a local SHM meeting. You can tell it's in the South because I feel like hot mess is a very Southern term. But disaster, confusing, duplicates, superfluous, excessive, complex, depressing. So us as hospitalists are clearly frustrated by and recognize that this is an important issue that we should be addressing. And I think our patients are increasingly recognizing this as well. If you subscribe to the Wall Street Journal or the New York Times or Newsweek, name any major publication, and there's been some article about the quote unquote hidden drug epidemic, that being polypharmacy or hyperpolypharmacy. And so I think your patients are increasingly recognizing this as an issue and are increasingly interested in discussing this. So to summarize, the epidemiology among my patients in the hospital, and especially those going to post-acute care, about 14 medications on average. Potentially inappropriate medications are highly prevalent. And hospitalization is associated with an increase in those medicines. And so myself as a hospitalist are partly the problem. And so we should be working to fix it. Let's talk a little bit about outcomes of polypharmacy. Now, polypharmacy is not new. I just like this slide because this is a VA study of a couple hundred patients. It was a prospective cohort study at one VA hospital. And they looked at patients who had been readmitted to the hospital. And they say, hey, what proportion of these are secondary to medication issues? And they found about a quarter of readmissions at that time they thought were medication related. Half of them were thought to be secondary to adherence, and the other half were thought to be due to adverse medication events. And here, they just on the first column, you can see the number of medications the patient had from 0 to 1 or 2 to 3 or more. Boy, I wish my patients were on 0, 1 or 2 or 3 or more. And even with that, they found that there was a linear relationship with kind of poor adherence and adherence-related admission in the hospital. And so you can only imagine if we have 10, 11, 12, 13, 14 medicines, what that might mean for our patients. Now, I am specifically, some of my old research is, and actually ongoing research is in delirium. And so delirium is just one of many geriatric syndromes which have been associated with polypharmacy. And in fact, the medication number, that polypharmacy definition of 5, was really based on looking at kind of AUC and sensitivity specificity curves of when there was an inflection point of the number of medicines and a number of geriatric syndromes, including falls, functional impairment. Here, this is a French study. It took about 400 patients who were consecutively admitted to a geriatric ward. They measured them all for delirium within the first 48 hours, and then obviously looked at and then measured it day by day. And they looked at the adjusted incidence of delirium given polypharmacy. Not surprisingly, the overall prevalence of delirium was about 25%, which is pretty normal and pretty standard for a geriatric ward. However, the odds of having delirium was double, was twofold greater among those who had a polypharmacy. Here, the definition was 6 or more medicines versus those who did not have polypharmacy. And so just one of a whole host of geriatric syndromes that we could cover. Now, one thing when I talk about de-prescribing, I think an important concept to note is that dose matters. You can note just with the case that I described at first, I didn't stop those medicines. The first thing we did was reduce those medicines. And that's for a couple of reasons. One is because some of them are not safe to reduce right away. Another is to get buy-in from your patients because they might have some fear or concern about reducing their medicines. And so this low and slow might be the way to go. And the third reason is a scientific reason. When one looks at dose is often related to really important incomes. This is a study from Group Health in the Northwest Seattle region, about 3,500 patients who were followed for up to 10 years with a mean of 7.3 years. And what they did was they looked at their cognitive status at baseline. None of them had dementia. And they did a cognitive battery every 2 years. And they looked at the incidence of dementia. One of the important predictors was the anticholinergic burden. You can see on the first column something here called the TSDD. This is the kind of the total standardized daily dose of anticholinergics. And more is a higher dose. It's worse. And you can see on the bottom, kind of the most common anticholinergics were antidepressants, first generation antihistamines, and bladder antimuscarinics. And an example of one that would have over 1095 would be 3 years of oxybutynin at 5 milligrams, or olanzapine at 2.5 milligrams, or meclizine at 25 milligrams. So all medicines that we're probably familiar with. And as you can see in the adjusted outcomes, as the dose increased, the incidence of having new dementia over the ensuing years increased up to 50% greater for that highest dose. And so one can argue that dose here really does matter. There's a clear dose outcome relationship. Another common measure of dose, and something that we've used in our research, is something called the drug burden index. And what the drug burden index is, it really takes the combination of sedative as well as anticholinergics. And you can see this big D over this sigma plus the big D. The big D is the dose that the patient is actually getting, what the patient is taking at that moment. And then you divide it by, the sigma is kind of the minimum dose that's known to be effective on the basis of either the WHO or the FDA is what we use. And so you can get, obviously, if you're not taking a sedative or anticholinergic medicine, then the number will be 0. Let's say the minimum effective dose is 1 milligram of some medicine. And if they're taking 1 milligram, then it's going to be 1 over 1 plus 1 or 2. So the drug burden index in that case would be 0.5. And you just add them up across the number of medicines. Generally, a number of less than 1 is thought to be a low drug burden index. And anything greater than 1 is thought to be a moderate to high drug burden index. And for each increase in drug burden index, there has been multiple studies looking at the increased relationship of falls, doubling the risk of frailty, and increasing risk of length of stay as well as admissions. So once again, that notice, and once these are for sedatives and anticholinergics, that when we talk about de-prescribing, dose really matters. I try to focus that it's not just stopping medicines. It's about reducing exposure to pharmacologic agents, which are known to be harmful for our patients. Now, finally, this is from our CMS study where we looked at patients going from the hospital to post-acute care. And we looked at the medications which were associated with geriatric syndromes and said, hey, among our patients who are going from Vanderbilt to post-acute care, what proportion of them are on at least one medicine associated with a geriatric syndrome? And you can see that, look at the kind of falls, 98% of our patients were on at least one medicine associated with falls. And if one looks at all syndromes, cognitive impairment, delirium, depression, urinary incontinence, weight loss, all of our patients were on at least one medicine. Falls is definitely, there are more medicines associated with falls than many of these others because, for example, antihypertensives and some diabetic medications would be on that list of associated with falls. So our patients were on about 5.5 medicines on average who were going to post-acute care that were associated with falls, and across all syndromes, 5.9. You might ask, which medicines are associated with all of the geriatric syndromes? And anti-seizure medicines are actually kind of some of the worst offenders with regards to being associated with pretty much all of these particular geriatric syndromes, if one looks at the literature. So just to summarize in terms of the outcomes, I didn't talk about all the geriatric syndromes, but if one looked at falls, incontinence, polypharmacy definitely related to that, increased risk of delirium, and just keeping in mind that dose matters, both the anticholinergic kind of standardized daily dose as well as the drug burden index. Now, what do we know about de-prescribing in acute care? So I always like this cartoon. Feel a lot better since I ran out of those pills you gave me. So let's just talk about what de-prescribing is. There's been many definitions. Ian Scott is one of the kind of great thinkers in the processes of de-prescribing. A lot of the great work that started in de-prescribing is out of Australia as well as Canada. And he describes it's the systematic process of identifying and discontinuing drugs in instances in which existing or potential harms outweigh existing or potential benefits within the context of individual patients' care goals, current level of functioning, life expectancy, values, and preferences. And so in my mind, this is really, it's just prescribing in reverse. One could say the same thing in terms of when we start a medicine, we should be thinking about care goals, current level of functioning, life expectancy, values, and preferences. And de-prescribing is just the reverse of this. So I'm obviously a hospitalist, so answering the question of why inpatient de-prescribing, that's one reason. It's because I'm a hammer and everything looks like a nail. However, I hope I've convinced you that hospitalized patients are a high-risk population. And so we'd like to do interventions among those that we feel like have the highest risk and maybe the most potential to benefit. There's a frequent exposure to potentially inappropriate medicines, and they're started in the hospital as well. So this might be a good place. There's a potential link and risk factor between polypharmacy and readmission and admissions and length of stay. And we have the benefit in the hospital of having a multidisciplinary team at our fingertips, not all the time. However, we have a little bit more time and space, and often the inclusion of a pharmacist on our teams that might be able to help us advance the needle when it comes to de-prescribing. And then finally, I think an important factor, and I'll talk more when I talk about post-acute care specifically, is we do have an ability to monitor patients for adverse drug withdrawal events. So getting buy-in for de-prescribing in the hospital may be easier because we can tell our patients that, hey, we're going to watch you. We have you monitored. We're going to be able to see if anything's going wrong. Whereas in the clinic, you may not be able to see them back for a week or 2 weeks. And that's where obviously using things like check-ins and telehealth might be beneficial today for de-prescribing the outpatient setting. So there have been a number of inpatient trials. This was a recent systematic review, and they found 9 trials, one that was in the United States that was focused on potentially inappropriate medications. Among them, they found a limited description of the interventions themselves. They often focused on explicit criteria, meaning that if they were on a potentially inappropriate medicine, they identified them and proceeded to try to de-prescribe. There wasn't as much focused on patient-centered de-prescribing and taking into account care goals and patient preferences. Many had a high risk of methodologic bias. Follow-up was limited. None were powered to look at secondary outcomes, and none focused on the post-acute care setting. Among the 9 trials, there were 5 that they could actually look at the mean number of potentially inappropriate medicines before and after with the comparison to a control. 3 of them, they found a statistically significant reduction. Those have a number 1 after them. And on average, it was a reduction of between 1 and 2 potentially inappropriate medicines for an intervention versus control. The predominance of these were pharmacist-based or geriatrician-based de-prescribing protocols with a focus on potentially inappropriate medicines. So it really proved that it could be done. All of these, many of them looked at secondary outcomes, but none were significant. But all of them also found it to be safe. There was no evidence of harm. Their conclusion, I put in quotes, they said, our findings suggest that de-prescribing interventions targeted at older adults admitted to the hospital can reduce potentially inappropriate medicines. The interventions appear to be safe and in some cases may be feasible to implement into usual care. However, the impact on clinical outcomes is unclear and the current evidence is weak and of low quality. More recently, there was a large, very well done, randomized controlled, cluster randomized controlled trial that was done in Europe. It had 4 sites and 110 different clusters. The clustering was done by inpatient ward. It was really done by inpatient attending within the university-based hospitals. There were 2,008 older individuals. They had to be 7 years and older, and they had to have 3 or more chronic medical conditions with the standard polypharmacy definition of 5 or more. They did a structured pharmacotherapy optimization, and they used what's known as the start-stop. Some of you may be familiar with this, but it's generally, in addition to de-prescribing, which is the stop, which has a high correlation with the Beers list, they also had the start, trying to recognize some medicines that may need to be started. So this one really looked at both. They combined the start-stop list and used a pharmacist as well as physician to help guide the de-prescribing among the each of the clusters. Just to summarize briefly the findings of this trial, there was 789 of the 916, or 86.1%, had at least one recommendation of a start or a stop, with a mean of about 3 recommendations and a total of 2331 recommendations were of stops. So 65% were stop, the other 35% were starts. And then when they said, oh, those were the recommendations, what actually happened? There was about 1 successful recommendation that was followed through. The majority of those were stops. So about 90% of those were stops and 10% of them were starts. So pretty modest reductions in medications. And their primary outcome was actually looking at drug-related hospitalizations. And they found no difference between the intervention and control. Importantly, among this group, about their mortality rate at 1 year was about 25%. So one of the reasons was, 1, they didn't have a lot of de-prescribing that happened, and 2, there was a large loss to follow-up as well in this particular population. But a very well done study. There was no evidence of adverse harm, and there was maybe a trend towards benefit among those patients with dementia and cognitive impairment. So that's just a brief summary of what we know about de-prescribing. There are other trials that are out there, but I'm going to shift gears and focus on some of the work and some of the findings that we have found with regards to our recently implemented SHED-MEDS trial. So when we started to think about this, as mentioned before, we were on the tail end of our CMS Impact Interact transitional care study and recognizing that our patients were on a whole host of medications. So this was a population we were familiar with, and we had a relationship with a large number of post-acute care facilities. And so there are a couple of advantages that we thought would be kind of present in this situation. One was just that ability to follow the patients from the acute to the post-acute care and to be able to continue the de-prescribing process between these 2 settings. The average length of stay in the post-acute care setting can be upwards of a couple of weeks. And so rather than just having one opportunity, maybe having multiple touch points to be able to reduce those medications. 2 is we found that looking at the literature, most of the inpatient de-prescribing trials were using explicit criteria, meaning that they looked at a PIMS list, a Beers list, a start-stop list, and they used that to guide most of their decision-making. Where we really used that as a starting point, but we really wanted to have a patient-centered and do what's known as implicit de-prescribing, where we would come up with a potential list, but really engage the patients with regards to a conversation about which of those medications did they want to stop, which ones did they have problems with, to be able to guide our de-prescribing protocol. Ours was completely pharmacist as well as advanced practice provider driven. We thought that was a more pragmatic approach compared to, for instance, in the operam, where it's mostly physician driven. We did not focus on a single disease or specific drugs. There's a host of literature where they look just at PPIs or benzos. We really tried to look at the holistic entire list of medications. And then finally, we tried to assess implementation barriers and facilitators to really help guide the next steps. This is a little bit about our de-prescribing framework. It is based on the work of many others, and many of it will look familiar to what you think about when you're prescribing and hopefully de-prescribing. We looked at the patient's disease factors. We looked at their goals, the risk, the benefit, the costs, their adherence. If a patient wasn't taking a medicine, we then recommended de-prescribing it. And we looked at appropriate treatment targets, which was a common issue among those treatment targets changing, diabetes medicines being one of them as an example. And then of course, we looked at medication-specific factors, whether drug-drug interactions, drug safety interactions. Was the patient admitted secondary to a fall and was on a whole host of fall-related drugs, and then issues about drug withdrawal as well. So before we got started on a large trial, at the very end of our CMS study, we did a pilot of 20. It was non-randomized. We used a historical control, and it really was just to test feasibility. Could we actually do de-prescribing in the inpatient setting and transition them to the post-acute care setting? So we looked at just 20 patients. We developed our de-prescribing protocol using our pharmacist and advanced practice provider. They were the ones who identified all the potential medications for de-prescribing. We then spoke with each of the medications about them. We came up with a list, and then we engaged the inpatient as well as outpatient providers, and I'll talk a little bit more about that. And then for this particular study, we did end just at hospital discharge from a feasibility perspective. We did not continue de-prescribing within the skilled nursing facility. And then our control was just a usual care medication reconciliation, which what we were doing for the Impact Interact study, but it was a historical control. And in our pilot, among the shed meds, the intervention population, what we found was that they had a total of 12 medications. This was at the end of the study, and our control had 16.6, and it was significant for what it's worth, but once again, non-randomized. It was just a pilot, but it really showed to us that we could do this. We could successfully reduce medications among our patients. The potentially inappropriate medications, they were only on 2.6, which is still a lot, but compared to the control, that was 4.1. And that drug burden index was also reduced at 1.9 compared to 2.5. Not statistically significant, albeit the main goal of this was feasibility. And we showed that yes, we could take care of these patients, identify them, and transition them to the post-acute care setting. So we found, once again, that de-prescribing, it was feasible. We also found that engagement was key. I'm going to talk a little bit about later for the main trial, but we made a lot of changes to what we initially wanted to do. And after talking to our patients, more than half the time, they influenced what happened with regards to the changes that we made. And then we really thought that the post-acute care could be key to make further enhancements to the de-prescribing. So starting in 2017 and just recently completing, we did a 5-year randomized controlled trial of de-prescribing among older inpatients who were going from Vanderbilt to a number of post-acute care facilities. Our primary outcome was just reducing the number of medications that the patients were prescribed, both at Vanderbilt as well as skilled nursing facility discharge. We did follow them for 90 days to look at the sustainability of our particular outcome. Secondary, we looked at the documentation of intervention effects on geriatric syndromes, adherence, medications, and functional health status. So patients had to be 50 years or older. They had to be on 5 or more medicines. They were discharged to 22 partner skilled nursing facilities or rehabs, home residents in the 9-county area around Nashville. They could not be in hospice care. They had to be admitted from a community setting, and this includes assisted living facilities where many of the patients manage their own medicines. And they had to be able to self-consent or have surrogate consent. This just is a map of our partnership. As mentioned, kind of why skilled nursing facilities. This is an important population. About 33% of hospitalized patients in Medicare do receive post-acute care services. And then as mentioned, we thought there was a particular advantage to be able to monitor these patients and get buy-in, not just of the patients, but also the providers, to be able to let them know that if we de-prescribe, we're going to be able to monitor these patients for a number of weeks. And so these are the 22 partner skilled nursing facilities and IPRs in the Nashville area. So this is just the timeline that we did. Basically, patients would come in, and we only saw these patients once a decision was made to go to post-acute care. And that was actually a little bit of a, actually not a little, but it was a big limitation of our study. Between the time of the Impact Interact study and this study, the distance and the time between referral to SNF and discharge had really shrunk considerably. So we really had a limited number of time, generally no more than 2 days, and often less than 1 day. So a patient would be referred to one of our partner skilled nursing facilities. At that time, they'd be randomized to either intervention on the bottom or control on the top. Every patient got a baseline gold standard best practice medication history, and I'll talk a little bit more about that. Among our intervention, we would do a baseline assessment of their medications. We did a baseline patient interview, assessed all their geriatric syndromes, and then we'd work with the patient to come up with a list of medications for potential de-prescribing. We'd connect with the outpatient providers, inpatient providers, and make ultimate de-prescribing decisions, transition them to skilled nursing facility, and our intervention really ends at the skilled nursing facility. There's no more active de-prescribing recommendations from our team. Importantly, we didn't do any of the de-prescribing. We just made recommendations to the inpatient team as well as the skilled nursing facility team. Ultimately, they would have to agree to pull the trigger and make those de-prescribing kind of actions. And then we follow patients at 7, 60 days, and 90 days. As mentioned, our primary outcome was total number of medications, but we did look at potentially inappropriate medicines as well as a drug burden index. And then we looked at safety measures, drug-related adverse events, including adverse drug withdrawal events, ED visits, hospital utilization mortality, and then a number of geriatric syndromes and as well. This just gives you a flavor of the participants that we were able to enroll. We had 372 patients enrolled over that period. The majority were female, majority were white. The average age was 70, or the median age was 76.8. They were highly comorbid, Charlson score of 6. Interesting, this next one, the proportion using more than one pharmacy was about half of the patients used more than one pharmacy. The number of outpatient prescribers was a median of 3. About 2/3 of the patients did get some type of assistance with taking their medications, and their total pre-hospital medications from all sources was 16. Now, if you remember, when I talked about the Impact Interact, the number was 14. And I'm going to explain to you about why that number is even higher in this study. And the biggest reason I'll say it's higher is because we did what I would consider a gold standard best practice medication history. So what is a best possible medication history? This is something that's just been kind of widely disseminated among Society of Hospital Medicine in the Marquis study. But really a best possible medication history uses more than 2 sources to come up with what you think is the gold standard. And in our case, we used all of these sources. We went above and beyond. So the default generally, when you come into the hospital, is the electronic medical record. Most clinicians are going to use that first medication list, which pops up. We started with that. We did a bedside interview. We looked at all pharmacy refills and we looked at every pharmacy that they went to. Remember, the median was 2. Tennessee has a controlled substance monitoring database, which we queried. And then we looked at any ancillary medical records that we had access to, including if they came from their assisted living facility or were transferred from a SNF. So what do we find? This just shows that in order to do great de-prescribing, you first need to do a great medication list to begin with. Because if you don't know where you're starting, then you may not know where you're going. This is a busy slide, but I'm going to draw out some things. What this is basically a comparison between our gold standard best practice medication history and what we found as that initial list in the electronic medical record, which most clinicians are likely going to be using. So to start, one can see that 90% of our patients had at least one medication discrepancy. Either we were missing a medicine, or we had an extra medicine that wasn't supposed to be on there, or there was some type of dose discrepancy. And there was a median of 3 among all patients. Next, the most common type of error was an omission, meaning that the patient was taking something that we just didn't know about, that our medication list was missing something. And if one looks at kind of where that information came from, the bedside interview as well as the pharmacy history were the most important. So if you're looking and trying to get support for a pharmacy technician, well, this is part of the rationale to do it. They're going to find medications, and some of them are important medications. I'll show you quickly about what those were. Additions were less common, but still important. About 40% of patients, we had a medicine that they actually said when we talked to them, no, I'm actually not taking that medicine. This was published in JAGS just this past year, and what this shows, the figure essentially shows, well, what were these medicines that had omissions, additions, and discrepancies? And you can see antihypertensives were the most common medication. So these are not vitamins or laxatives. Granted, those were there as well, but non-opioid analgesics, probably not as important. That's likely Tylenol as well as NSAIDs, which are important, anticholinergic medicines, opiates, et cetera, et cetera. But most of these are really important medicines that we're missing. So as mentioned, for de-prescribing, you got to do a great medication list first. You have to do a great best practice medication history. So what we would do then is, once we had this list, we independently and without the patient reviewed their medical record and said, can we kind of do we think this patient should be on the medicine? So they have an indication. Is it inappropriate for their current indication? Is it unclear if it's effective or not? Are there more than one medicine for the same indication? Is it a high risk? Is it a PIM or a stop medicine? Are they inconsistent with what we can tell with the goals of care? But this was all based just on the medical chart. So we'd come up with a list purely by reviewing the medication record without talking to the patient. And the most common, I highlighted no indication for the medication, or it was unclear. That was by far the most common reason that we listed a medicine for potential de-prescribing. PIMS was number 2. So how did we come up and decide what was a PIM and what should be de-prescribed? We relied upon a whole host of literature. I'm just going to highlight a couple of resources which I think are important. De-prescribing.org, the group up in Canada, they do tremendous work and have come up with wonderful guidelines for when and how to de-prescribe PPIs, benzos, antihyperglycemics, antipsychotics, benzodiazepines, cholinesterase inhibitors. So check it out if you want really good information on when and how to de-prescribe these medicines. This is exactly what we used for our protocol. Since the inception of our study, there's been the U.S. De-prescribing Research Network, USDEN, also a wonderful resource. Check it out at deprescribingresearch.org. A lot of guidelines, de-prescribing videos, general approaches, a wonderful resource. So those, if I went to 2 places, those would be the 2 places I would go as a clinician. So once we came up with the list, we would then talk to the patients. And we would do a patient preference interview. Part of the interview was just about overall general approach to medications. And then once we got singled in on some specific medications, we would talk about them. We wanted to know about their knowledge, their adherence, side effects, their preferences for stopping, and their willingness to decrease the dose for some specific medications. But we really engaged them, and we based a lot of our discussion off the brief medication questionnaire. So one of the tools we used is kind of something called the Attitudes Towards De-prescribing. This is a tool which has been revised. There's now a kind of a revised Attitudes Toward De-prescribing, but we use the original version. And these are basic questions that you can put into your general clinical care. Do you feel like you're taking a large number of medicines? Are you comfortable with the medicines that you're taking? Do you believe all your medicines are necessary? If your doctor said it was possible, would you be willing to stop those medicines? So you can see overwhelmingly, the columns here, there's the overall response, and then there's the patient versus the surrogate. Surrogate was when the surrogates were the only individuals that were able to respond because of cognitive impairments. And so overall, patients, more than 2/3 of the time felt like they were taking too many medicines. Interestingly enough, though, the next one is the majority of patients are comfortable, even at that number of 16, they feel comfortable. So there's this little bit of a disconnect. But at the very bottom, 90% of patients would be willing to de-prescribe if their physicians were in agreement. However, 61% feel like that they're necessary. We did look at patients versus surrogates, and in the older population, oftentimes you'll find that indeed about 20% of our time, the surrogates were the only individuals available. Most of their attitudes toward de-prescribing were the same. The only ones were different were that surrogates more commonly felt like their medicines were not necessary, and they were less likely to take finances into consideration when it came to de-prescribing or not. But otherwise, all their attitudes were very similar. So we did a whole bunch of patient preference discussions. If you remember, that OpRamp study had like over 1,000 patients and they did about 1,900. We only had 177 patients, and we did 1,405 medications that we discussed. So we spent about a half hour with each patient, and on average discussed about 5 medications per patient. And you can see kind of, well, what were they agreeable to our kind of willingness or want to de-prescribe? And overall, 2/3 of the time, patients were agreeable with our de-prescribing recommendations. Now, this doesn't mean that those got de-prescribed. This is just the first step of saying, hey, we presented them the medications, and 2/3 of the time, they were willing to do it. They were more willing with diabetes medicines, benzodiazepines, antihypertensives. Something which surprised us is the lowest agreement was actually vitamins and supplements, which you would think are the kind of the lowest risk medicine to stop, but they're the ones that our patients were the least likely to want to de-prescribe. And opiates was about 61%. So we, of course, are interested in, well, why do patients want to do it or not want to do it? What's their willingness? So we looked at Emily Reeve, a wonderful researcher in de-prescribing, kind of created this wonderful framework for the willingness to de-prescribe, and talks about the barriers and enablers being appropriateness of cessation, fear, I'm worried something might happen, influences, my patient or my doctor says I should or shouldn't, dislike, have I ever had a bad reaction to it? And then the process, is it just a pain to reduce these medicines? The titration schedule is too hard. I just don't want to deal with it right now. So when we looked at kind of the barriers and facilitators to the barriers when the patients disagreed with our de-prescribing decision, or the facilitators when they were agreed, the most common barrier was appropriateness, that they just felt like that those medicines were necessary for managing their medical condition. Quote, I had a flare when I neglected taking it one time, or could have continued future benefits. This is the only thing that helps. Or I've been taking this for years and I've never had any harm. Process was far less common. For example, let's wait until I'm more stable to change this medicine. And the appropriateness was the most common. In terms of fear, the only time fear was a common one was actually for antipsychotic medications, interesting enough. And the only time process came up as particularly important was for anti-seizure medicines, as the process being an important one. For facilitators, same thing, appropriateness. They would agree, like, hey, I see what you're saying in terms of I've had really low blood sugars, and so this makes sense for me to stop this diabetes medicine. Or they doubt the medication necessity. It's been taking a long time and doesn't know if it helps. And dislike was less common. So she states the medication inflames her throat and nasal passages. She doesn't like it. And so those were situations where it was easy to get buy-in for de-prescribing. So importantly, after we talked to the patient, we talked to all the providers, both outpatient and inpatient. We're just kind of diving into this, so I don't have as much information, but we were able to get a hold of about 3/4 of outpatient providers. A quarter of them we actually couldn't reach. So it raises challenges that with care coordination across care settings about the process of de-prescribing. And we discussed on average about 4 to 5 medications per patient when we talked to the primary prescribers. Most of the time, the primary prescribers agreed with us, right? So the patients agreed with us about 80+% of the time, and the providers also agree with us about 83% of the time. And most common, it was kind of like, I just agree with you. We call it tacit, that maybe because of time and resource complaints, they didn't have the cognitive wherewithal to really dive in and kind of go with us. And then barriers, there's some inertia, general resistance, and maybe some need for support systems, but we're just kind of getting into this data. So, and then the final thing we would do is we would do hospital de-prescribing actions. And this is just to kind of remind everybody that de-prescribing is, once again, it's not just stopping medicines. And some of them we would stop at hospital discharge. We'd stop and monitor in the SNF. We'd say, let's stop it later. You can titrate down and monitor. You can just decrease the dose. You can decrease the dose and monitor. These were all different actions that we decided upon. And then, or we would continue the medicine, add a medicine. Those would be the non-de-prescribing actions. Importantly, kind of once we got done, we would do a warm handoff with a skilled nursing facility provider. We'd ensure the correct medication list. We'd communicate de-prescribing recommendations and actions and monitoring instructions, and we'd check in once per week. We would look at the medication and administration record, and we discuss symptoms and medication changes and try to continue the de-prescribing. And wrapping it up, we created a comprehensive list at SNF discharge and provided it to all the outpatient providers. We included a list of detail of what had been de-prescribed and why, and also provided further recommendations. We were not active, this was passive, just say, hey, keep going, see if you can keep doing this. Importantly, for those of you who are trying to de-prescribe in the hospital, but also in the clinic, make sure you stop the refills. What we didn't want to have happen is say we de-prescribed it and the next thing the patient gets home and they have some refills which show back up. So you have to call those pharmacies to stop them. So I don't have, we're kind of tying up our results. I'm sure everybody wants to know, well, did it work? Did it not work? And so that's soon to come. I would hope to come back and give some results with regards to that. But this is what we've learned thus far. Just coming back to the case that I had, I did follow up to see, well, what happened to this patient after I discharged this patient. The patient did follow up with rheumatology as well as pain clinic. And this was about a month later. The Benadryl had been stopped and changed with loratadine. Her clonazepam was down from 2 milligrams down to 1. Her hydromorphone was decreased from 4 milligrams to 2 milligrams 4 times a day. Her naproxen continued to be off the list. Her methocarbamol was at PRN, but a decreased frequency. She had naloxone spray that was prescribed. Pregabalin now was down 75 milligrams daily from 3 times a day. She was on prednisone, and that was continuing to be titrated to off. And she was referred to neurology for consideration of de-prescribing of her carbamazepine. So I would consider this a success. And the patient had not been readmitted at that point. This patient was obviously not part of our trial because it was less than 50 years old. So I just want to thank, we have an amazing team of folks who help with all this de-prescribing work and transitions of care work. My co-PI, Sandra Simon, our project coordinators are amazing. You saw their names on many of the articles. Our geriatric nurse practitioners and pharmacists couldn't do it without them. And then of course, the support of the NIH, the VA, CMS, who've really helped support a lot of this work. With that, I'm happy to take any questions.
And thank you so much for really important cutting edge work that I think makes so much sense to all of us as we hear you talking about it. I think it's sort of something that we feel like should be happening. And so thank you for taking the lead on that. Questions, comments for Dr. Vasilevskis?
I think Dr. Javed, thank you so much, Dr. Vasilevskis. Amazing talk, really pertinent to us residents as well. I think Dr. Javed has a comment in the chat. Thank you so much. Great information. Another important aspect of polypharmacy is the impact on patients. Taking 5+ meds daily is not easy, especially in the elderly. It's so easy to start medications, extremely hard to stop. We need to think about prescribing. Thank you so much, Dr. Javed. All amazing points.
Yeah, I just wanted to say, like, I have 2 elderly parents, and I just continuously see them struggle with the prescriptions, and it's hard. It's hard. Like I've never thought about it. And I always tell my students and residents that it's so easy to start medication. So easy. You can prescribe and done. It's so
Yeah, I
hard.
was going to say one thing I didn't mention is one of the huge benefits for the skilled nursing facility and the hospital is nursing time, the amount of time that's needed to administer all these medicines. And so getting skilled nursing facility buy-in was really easy. And also skilled nursing facilities often have to pay for the medication administrations. And so they're very much engaged and willing partners with regards to with de-prescribing. And I'm sure your hospital nurses would be very willing partners as well.
Thank you so much. Dr. Berger, I see your hand up.
Yes, thank you for such an amazing talk, a really thorough, sort of long review of some literature that's been going on for a while and we seem to ignore it. Every 10 years have to reinvent it. Wanted to just sort of bring up, because we present this often around here, or not often, but the newer paper that maybe as you were developing this kind of came up concomitantly with the MedSafer paper out of the Canadian system, where their conclusion after doing another one of these cluster trials by hospitals was that while de-prescribing medicines, I think we should also point out, and you talked about this, that it's not always the benefit of, like, you got rid of a medicine on the Beers thing, or the PIMS, where it's causing harm, yet can cause harm, but that by removing them, there is no harm. And therefore, we're decreasing the pill burden, as Dr. Gervais just talked about with his parents, or and we're just decreasing the confusion about what to do, and that withdrawing these medicines doesn't actually cause any harm. And we should be more active about it. I wonder if you, even though it wasn't expressly as part of this, but if you had thoughts on what their conclusions in the context of this larger stuff.
I agree. And even with the context of our study, of course, we would love to be able to say that we lead to clinical outcomes. We're not necessarily powered to see that with regards to our study. However, I think also looking at that OPRAM study, among the older patient population, and ours included, our mortality rate was not quite as high, but still substantially high. And so these are very sick, comorbid patients. And so it is not surprising to me at all that one would not find a statistically significant difference in any geriatric syndrome. However, I feel like the literature is very strong to say in the systematic reviews that there certainly is no harm. So if you reduce pill burden, think about the burden on the families, as I mentioned, the nurses, the cost. They're all going to two plus pharmacies. If we can get them down to one pharmacy, and I'm interested. We haven't looked at it yet, but the adherence issue as well. As you mentioned, I mean, it's hard to take 5 or more medicines. How about 16? So.
Dr. Risk, I see your hand up as well.
Hi, Ed. How are you?
Hey, good to see you.
Good to see you. I think we're always so focused in the compliance and adherence space, and always wondering if our patients are taking any of the medicines that they're getting, that we don't even have the brain space to say, actually cut down on the regimen. So I do think it's a really important effort. I think we also view ourselves as guests in a hospital course, as opposed to like the drivers of a lot. And many times hospitalists are the drivers of these advanced care conversations, of these like what's really happening, that like fragmented care that happens in the community. I think there is an opportunity to really get focused in this space. So I appreciate that hospitalists are doing this important global view, and that there's such great academic hospitals out there doing this work. So thanks, Ed. Great to see you.
No, it's my pleasure. And I can say it's definitely a revolution, and it's my own clinical care. And I can tell you, I'm definitely known as an active de-prescriber. And when I talk to I call providers all the time now, which I didn't used to. And more common than not, way more common than not, it's, oh my gosh, thank you. I've been meaning to address that. I've been meaning to do that. Oh my gosh. So just, it's kind of that, do a test of change, just try one, get a patient who's on 14 medicines, and you get this little warm fuzzy feeling when you reduce a medicine and you think you may have done something. At least you didn't cause any harm and may have reduced their pill burden.
Well, we're at the top of the hour. Dr. Vasilevskis, I'll thank you again. It was a real pleasure hearing from you and hearing about your work. And yes, we will invite you back in the future for an update.
Hey, thank you so much for having me. Really appreciate it. And anybody who's interested, please feel free to reach out. I'm easily available. So.
Thank you so much. Thank you everyone for joining. Have a nice day.